All right, thank you guys so much for coming. So this is a small group today, Friday, Sono games and a few other things, but we appreciate you taking the time to come talk to us. I'm Brendan Munzer. I'm from the University of Michigan. We'll just take a minute to introduce ourselves and then we'll get started.
Yep. I'm Will Peterson. I'm one of the residents at Michigan and starting an education fellowship next year.
You guys don't necessarily need to come up.
How are you? I'm Robin Hemphill. I'm the Chief Quality Officer at VCU in Richmond, Virginia.
You can just stand up and...
I'm John Burkhardt. I'm one of the UW faculty that does educational research and some other things.
Laura Hopson, I'm the residency program. I'm going to include you anyway. Residency program director at Michigan.
So what this session is it's a discussion of two different articles, one on power conflict and team management, as well as ways that we can improve our feedback. Before we got started, we thought a good way to kind of introduce things was to do a small skit. So I'll introduce Will.
All right. Ring, ring, ring.
Ring, ring, ring. Just going to ignore this. It's just Will. He just wants to admit a patient. I remember him when he was a resident. So stupid.
Ring, ring.
This is Dr. Munzer, the pulmonary ICU attending.
Hi, Dr. Munzer. Thank you so much for picking up. This is Will Peterson in the emergency department, one of the residents. We worked together back a couple of years ago.
Yeah, I remember.
Thank you so much for picking up. I wanted to talk to you about a patient we have down here who's pretty sick and I think will need to be admitted to the ICU.
Okay, tell me about him.
Thank you. So she is a 79-year-old lady, came in febrile, tachycardic, has a UTI down here. We think she probably has sepsis from a UTI. We've given her 4 liters of fluid and her blood pressures are still on the low side. And we wanted to get her admitted and start her on pressors.
You only gave 4 liters of fluid? Pretty sure we can do more than that. Why don't you give her a couple more liters of fluid and then we'll get her to the floor and it'll be fine.
Well, sir, we thought about that, but she has a history of some diastolic heart failure and an ultrasound, point-of-care ultrasound in the room.
Don't talk to me about ultrasound. That's not even a real thing.
Okay, yes, sir. We're just concerned that she probably wouldn't do well with more fluid and might need to be intubated.
Look, I'm the attending. I'm not going to accept this patient until you show me that she can't tolerate more fluids. Now give more fluids and we're done here.
Okay, thank you, sir.
All right. So what we'll do now is we're a small enough group, so why don't we just kind of all come together and we have a couple of handouts that go over the articles. It looked like the articles did not get uploaded, so I don't know that you all had a chance to necessarily look over them, but what we can do afterwards is we'll have a piece of paper and we can send them out so that you can review them. Okay? So maybe we can just make a small circle. We'll go on this side of the room and we'll all join together. we're a small enough group that maybe we can just introduce ourselves real quick beforehand so we know everyone is here.
Charles Maddow, University of Texas, Houston.
Welcome.
Charles, oh, Mike Blue, University of Rochester.
Lori Thibodeau, Albany State Career. Judith Monchi at Eden School of Medicine.
Rick Commerce, Western Michigan University. Dave Wade, Ohio State University.
Paul Green, University of Texas, Southwestern Dallas.
So yeah, I'll try and summarize the first one. It's a challenging article, it's long. So there's a couple of things that we were building this around this. And the myth that we were sort of putting with this particular article is that conflict in teams is avoidable. I'm not sure that's a well-established myth that everybody would say, but I think that maybe we should just say that sometimes we're very good at avoiding conflict and thinking that we've avoided it or something along those lines. But so this article is called, what's the name of this article?
So it's called What is Happening Under the Surface? Power, Conflict, and Performance in Medical Teams. Just to kind of summarize it really quickly and put it in a nutshell, is they do a really good job in this article of giving you a method by which you would say, I could really deconstruct the problems in terms of what's happening in my team. So in other words, they go through this and they define out these things called pre-existing power perceptions, PPPs, that then they go through and for the rest of the article. And then they have pre-existing conflict perceptions. And so in each one of those, so for pre-existing power perceptions, is that when teams come together, there's almost always some perception that each individual has about the power dynamic within that group. And if it plays out correctly, then maybe there wouldn't necessarily be conflict because everybody would play their appropriate role as each one internally perceives. But in instances such as the case that you just saw, if you have somebody who would say, I'm the power person here, which in the ED we often find that everybody thinks that we're followers when we call them to consult, we'd say, I'm trying to do the right thing for a patient, so I am a leader, and I need to try and get something for my patient, and yet the individual I may be engaging with in an ICU would say, I'm the leader here, and you need to do what you're told. And so, again, that's a little bit of an exaggeration of something that's a much more subtle dance than that, but that, again, is power dynamic. And then at times, if you were to think back about a conflict that you saw in the team, you'd likely see that somewhere in here people felt like, I'm in charge or I have a role and you all are not working with me on that role. So again, slightly oversimplification. And then the other issue is that whether or not people even perceive that there is a conflict. So do people in that group actually see that as a conflict as it's happening? Because again, if you don't see this as a conflict, then effectually, and that would often be the person in power would say, I don't see a problem here, there's no conflict here. But a lot of the other members of the team would say, that was really horrible. It was not a good engagement. We felt like somebody was kind of a bully in the room not listening. And so again, you have this power conflict dynamic that's happening that may or may not be perceived equally by all. The article goes through in much greater detail about, again, types of conflict and types of interaction. But certainly I would argue that at the end of this article, you would often be able to say, okay, I can much better define what just happened here if you feel like an encounter with a group did not go well. I'm not sure it gave you really good solutions to, so what are you supposed to do about that? Kind of again, in a nutshell, we would have said teams, team dynamics, team training would potentially allow for some of this, but there really was not a very good set way of if you have this relationship and you've defined it, if you do these three things, it would take care of that. The article really does not go into that depth. So using some of the kind of discussion points that are here on this outline that we have, we talk about kind of the different types of conflict that exist. And we talked about kind of task-related conflicts, essentially, kind of, if we were looking at the conversation that Will and I had, the task-related conflict that we were discussing was whether or not the patient needed more fluids, and this disagreement that we had. There was also this power, this relationship conflict. I was, to put it politely, an asshole, and Will was a timid resident. And so kind of knowing that there's that asymmetry there, that affects that conflict and that like, management between the two. And then there's this kind of process conflict. Who owns that patient? Who is responsible for what's going to be happening with that? So those are a few different things that can cause some of this tension, some of this conflict. And then from there, there's also this power differential. I'm an attending, he's a resident. We've had a prior relationship, and that all affects kind of everything that's been going on. I'm curious to hear about some of your guys' experiences, so then maybe we could hear some of that and maybe start breaking that down into different types of conflicts that we see within that. And that might even bring us to some solutions on how we can identify it and how we can use that to improve those situations.
You know, I think an interesting point in the article we talked about too that may help jog your memory is that medical teams are often ad hoc and change. And so the team dynamics are different than in like the corporate world where you may have the same team for weeks or months. Whereas especially in the example we had here, that team was, you know, aligned briefly, and you can think about a trauma resuscitation where you have a surgical team and an emergency department team, and in some institutions an anesthesia team. And there can be all three of those kinds of conflicts, and it may be different people every time. And so I think being thoughtful and aware of how these things arise does have to give you the ability to maybe diffuse them in a different way, but makes it a much more challenging thing because it's not the same team. So
I think that I think first being collegial and empathetic and trying to understand where the other person is coming from, regardless of who's in power, is really important. But I think that, at least in our institution, everybody has very, very clearly defined roles, sort of like in the airline industry. You know, we'll be a team unless there's something that must occur right now, and then all of a sudden it's my airplane, it's my patient, and we just have to do, you know, and ultimately it's, at least in our institution, it's always the ED attending who, you know, is over everybody else. But that doesn't give us we shouldn't behave as though we are the king and everyone should bow to us. We should encourage team dynamics and teamwork. And one of my very sickest patients, it was actually one of our techs who spoke up and felt comfortable speaking up and noticed something that not another person in the room noticed, and that ended up saving the patient's life. So I think having a very open collegial environment where it is a team so that people can interact and suggest things and mention, hey, did you know this?
yeah.
Great one line in here that you're like utterly Captain Obvious, but high-powered individuals are less accurate in detecting the emotional states of other people. You're like, yes. And you know, to your point about team training, most of you at your organizations done clinical team training with other departments, so interdepartmental and interdisciplinary, so nurses, techs. Because many places are doing it within their own department. So the ED people may have done their own team training, team steps, whatever you want to call it.
Even their job.
And has it helped, do you think?
Well, I think maybe because we're one of the old, you know, we're a very old department. So all of those fights, you know, happened 20 years ago. So we're not, it's just sort of already established. So I guess
But it's becoming a norm, so it's sort of the culture now, because if it becomes your culture, then when people enter into it, they look around and say, this is weird to start with, so the way the teams are engaging, but they'll pick it up because it was the way you do things around there. As opposed to a more hostile culture, you could come from a place that had done nice, good training, enter into a place that does not do it, and you will stop doing it because it's clear that it is unwelcome.
So, that sounds great. I think I wanted to tell you. We have some of those conflicts still. And one of the ways I try to diffuse these kind of questions is thinking about why the person is reacting in their own way, and then trying to reconceptualize the discussion as, I want to understand your point of view, because this is what I think is best for the patient, and I know you want to do what's best for the patient as well, and we have a disagreement. And so explain your thought process, and sometimes that allows people to take a step back and realize that we're all on the same team. Sometimes it allows people to explain their rationale in a less heated way, and sometimes it allows people to reflect on their own choices, on whether they're making a choice because it's what they think is best for the patient or what they think is best for themselves, without accusing them of that. So I found that to be sometimes a very helpful way, again, to recognize that there may be, this article has a good example between an anesthesia attending and an ICU attending fighting, where the who owns what is less clear in a resuscitation on a code, where people all kind of come flying into the room, nobody really knows who's in charge necessarily if there's not clearly defined roles. Everybody has an opinion, and there's a task disagreement, which can be, as you talked about the tech, can be a place where you actually can improve patient care through leveraging that conflict. You have to get through these other ones, and part of that is in changing it from a personality conflict of I'm smarter than you or you don't know what you're doing to I have this opinion, you have this opinion, let's discuss them. Because it's not the same heated debate, I think. I don't know if anyone has any thoughts about that, or is it issues where they've been in conflict like that, or?
The circumstance with a trauma patient blood trauma, who required the positive fast, and hypotensive but blood responsive, which is what we go with. And the trauma service, including the attending, we're insisting on going over CT next. And I kind of just, with the familiarity, kind of came up, when did somebody take this guy to an OR? Which plants, indirectly, it's.
In team training, we call that hinting and hoping.
Okay. Yeah, and I kind of like hint and hope as a first step. With the example of, say, the ICU attending, I try to gain confidence and comfort by recognizing the power that I have, which is I can make somebody work. And I had a burn patient who required intubation, and the burn attending kept complaining about the patient having been intubated. Wasn't insisting, but just kind of going on in an insulting manner, about that, and even tried to pull, and I've been here for 5 years, and blah, blah, blah. To which fortunately I was able to reply, well, I've been here for 7. But that's really beside the point. But, you're welcome to come down and extubate them, because daring someone to come downstairs, daring someone to come and work anyhow, backed up by the, no, really, I want you to come downstairs now under my privilege. I know it's ultimately I have that backup, so there's a comfort.
It's just a few other things in the article, and again, it's kind of early in here, so you don't necessarily let the slug do the whole thing, but they define the different types of conflicts: task conflicts, relationship conflicts, process conflicts, and their only point here is to say that process and relationship conflicts are found to be negatively related to group outcomes, whereas if you can move it into a task conflict, that it can be a little bit less emotionally and overwhelming. So if you can sort of move out of, I know that you're the attending, or you feel like you're the, whatever. We need to kind of move into what tasks do we think would be best to help this patient now, where we can, kind of get more into the what you hope are sort of the facts of good care. So, the potential that you can diffuse that a little bit, particularly if you would say, I'm an attending, you're an attending, or if it's your senior residents. But I think in the moment when you're a little kind of peeved, it is hard to try to make that switch. Which in part is why, team training at least helps establish the relationship to start with. So again, in aviation, I think we sometimes have a perception that these people all work together every flight. They really don't. And not only did I see that and go to Delta and ask that question, like, why can't you schedule it? You really know each other over time. That's just not what they do. But I also was flying back and forth between Detroit and Washington, D.C. for several years, and you would think that I would have gotten to know, because it was the same time, you'd think I would have known some of those crews at the point, and almost never did I see the same crew. So then you start watching what they do and how they come together, make their introductions, a few pleasantries, remind each other sort of their roles, and then off they go into their sort of checklist and other things. So this just brings people together, doesn't care if they like each other, these are the tasks, these are the roles, and off they go. It's kind of, I was just amazed. I'm sure I'm going to make friends with somebody here if I'm doing this for 4 or 5 years, and I just never saw the same crew.
Can I?
Please.
Can I share your problem you might help me solve this solution? So I'm from Taiwan. In our ED is pretty new, and I think so many departments is very big. So I look down us. Even if we work so hard, I think we have so many conflicts with many departments. Then often blame us, like if outcome bad is because starting point is bad, but it's difficult. You see patients with limit. History taking, you do the best. You should come to do, and what will be happen? Okay, I will show you one example about us with infectious disease. So I don't know what reason behind, but they would like us to consult fellow infectious before we empiric antibiotic for sepsis shock patients. And the problem is delayed. It's not lean at all. And I think in America you can empiric antibiotic whatever you want, but I think reason behind they don't want to have antibiotic resistant. So we try to find the evidence base. We made a conference with them among other staff, and the outcome that we get, we just negotiate to be 30 minutes, not only one hour later. If 30 minutes we consult a fellow infectious and they didn't answer, we can employ antibiotics. But that's not nonsense at all. I think if they would like to improve empiric antibiotics, they should teaching, give education to every department, not focus to only us, emergency department, and might give information about update data of antibiotic resistance in hospital. We will do that, and I offer that, okay, we should have a conference every 3 or 4 months to review what's happening in this, what the pitfall we can improve. We are doctor, we can acknowledge us. And the center is patients, it's not conflict among us. What is the best strategy for patients? So, but
Right, and I think sometimes in those cases, there's both an interpersonal power dynamic, but there's also a departmental power dynamic, right? You're in a new department, they're in an established department. They've had control over this for this time. They don't want to give up that control. I think in the States, I would say anesthesia is one of the departments we sometimes have, at least we had the sedation meds. That was a long negotiation for a number of years about what meds we could be allowed to use safely. There's other ones, nerve blocks are the new frontier for us, ultrasound nerve blocks. And it's good to recognize, you know,
it's just only one example.
yeah, no, of course. You have to convince me.
It's like, so for the places that have had 25 years of fighting these battles, I think this might be a good conversation to have a little bit after, because I think almost every department feels your pain. I started in a department that was pretty new, and you could just feel pulsating hatred through the phone when you would try to call for an admission. I mean, you just knew they were angry that you were there and angry that you were doing that, and yet you're like, well, you don't want to do it, so then, but I think we probably need to move into the next article, just because this again is a really, I think, interesting article around feedback.
Does someone else, maybe, George, you want to summarize?
Otherwise, I can take. So I actually love this article. I love this article because I think it encapsulates a lot of what we probably know intuitively, and really tries to make it explicit. So it's a linked series of articles by actually a psychiatrist who started looking at the model that in psychiatry there's this concept of a therapeutic alliance, that actually the relationship between the patient and the treating practitioner is equally as important as what technically is done. And the authors have really taken this to the whole concept of feedback. And this also jives with some other research in the field. And really, in very broad strokes, go on to say that feedback is filtered through judgments about the person providing it, not only about the quality of the content of the feedback, but what is your relationship with that person? How invested are they in the educational process? What is your judgment of their skill in the domain that they are providing feedback? So if I'm working with Joe and I have failed at it, he's witnessed me fail at airway management or fail at team management, and I'm giving him feedback about his own team management, that is probably going to be discounted. And other literature would say that's particularly going to be discounted if it's negative or constructive feedback. So I think that raises some particular charges or challenges for us as educators to look at our own skills and recognize how what we say is going to be filtered through the lens of how we perform. So what are folks' thoughts?
I'm really looking at this graphic, kind of that performance review and incorporation portion. What we're seeing with this concept of the educational alliance is really the way that it affects how we incorporate feedback. And that's kind of where we reconceptualize how we view things, and really is a powerful lens in which to kind of look at everything.
Just a question. That's a wonderful, I hadn't thought about that. And it makes me nervous because I'm certainly not a perfect role model by any means. Is there, I'm sorry, I didn't get the article.
No.
So I
Yes, we got uploaded, but they didn't go into ether nowhere.
I feel like the
Will show up on
didn't read those, we'll get them to you later. But did they mention anything, or would this be an opportunity when if I recognize that I did something inappropriately, like perhaps I had a bad interaction with somebody on the phone, or perhaps I had something go not quite as planned, would that be an opportunity for me to then highlight what I did wrong? And
so I think those are the best teaching points, because they're the hardest, because they open us up even more than I think teaching does in general. Makes us vulnerable to show our own flaws, even though we show them regardless of whether we are cognizant or aware of them. And I think an important idea from this article in general is you don't have to be perfect about everything to be able to give constructive feedback. But the person has to realize that you have insight into your own strengths and weaknesses. To have that, and another big part of it is that you have authenticity in your roles as educators. Another thing that was a theme through this was, if you don't seem to give a crap about teaching, then you can be the best in their way and give them advice, but they're like, they don't care about me. They're not engaged with me. They're not invested in me being better. And that was a thing they talked. There's a qualitative study that was part of this. That those themes came back. This idea of they're doing this perfunctorily because it's required as being part of academics versus really having a commitment to education and a commitment to me as a learner, which I think is all part of this kind of idea. It's very challenging in emergency medicine, I think, especially. One of the things I thought was interesting with the article is these themes emerged that kind of supported their thing. It's like, yeah, but you're doing it to psychiatrists who already are doing this, right? Like, no crap, that's going to come out. But we have learners coming on and off. We have one shift with them. They go off to different, departments. They're not ours. Even our own interns treat them like, 5 times in their first year because we've sent them into exile.
John, can you identify at least 2 members of your audience as belonging to your department? Okay. Yes.
Yeah, these 2 are in my department. This one, Guy 1, and Mr. Glasses. Mr. Glasses is older than Guy 1.
So, again, to your question though, this is an article that again, can't quite give you the answers to this conundrum. They acknowledge that these are psychiatry residents, that there's a longer-term alliance that they're establishing here, but it really did let them interview, and the article goes through some very specific dialogues that these residents have about how they end up feeling like that person gave me some bad feedback, but I really took it because I think that person is excellent at X. They also, therefore, yes, acknowledge that that they're there for a long time, and so they don't know what this means to residents or things that would be a shorter-term alliance. But it's another one of those things in the bucket of why feedback not always seems to work, that you're sort of like, not sure what to do with that. But
I think, yes, we have a short-term alliance, but at least on the one angle, you have a long-term alliance with a class. And your reputation spreads amongst the class very rapidly. And so you in working with a resident, an intern particularly, that you've never worked with before, they already know what to expect of you. And you have or don't have credibility on something. And as to the failures, if it's a failure at a point, I'll just say, if that didn't go well, here's what I think happened. Or if you have failed and they've seen you fail, you can reference, the last time I had this trouble, I knew when to step away and let somebody else do whatever.
I think that's an important point to bring up.
I was just going to ask if it would help the recipient be more receptive to your feedback if you ask for permission. Would you like feedback on just kind of they say yes, then they...
Well, our residents are very adept at group me, and if one of the attendings has a bad performance, they're very adept at telling their colleagues this is not good. And unfortunately, we discovered that. I don't know if y'all ever noticed any of these or been privy to them. Usually we're not. But we had some things get a little racy in their descriptions of what one of our attendees should do with their ultrasound probe. And one of the women found it offensive and let our female program director know and took screenshots of some of these. And they were not just a little offensive, they were highly offensive. But more than that, it let us know the residents do a lot of talking among themselves about what the attendees do or don't know. And if you have a good reputation, it makes it a lot easier to give feedback, obviously, which is, I'm sure this article also confirms. But if you happen to get a bad reputation, I'm not sure how you get out of that with social media now, because they're very rapid. We recently had our vice chair take a new job as a chair out west, and I don't think she was finished with their negotiations, and California school let it leak that she was going to be a new chair, and we found out about it at court through social media within an instant because somebody made a comment at a bar. And so it's like you can't even get a job anymore without social media getting in the way, and it's fantastic how quickly these things spread now. So if you have a bad shift, your entire residency is probably going to know about it within maybe an hour.
I think, I'm nowhere close to perfect. There are moments that I just slipped. So I think what I did was if there's sometimes there are some heated conversation with the consultants, we may have conflicts, and then I would once that or if I realize that that didn't go well in my residence, that I just kind of so that was a bad example. So don't do that, and then we can talk about how could I have done it better. But I think to make it the same, we are people and they are people, we make mistakes, but at least you can learn from my mistake and then don't do it.
And I think that maybe how you kind of recover from these kind of things is to try and rebuild that alliance by being honest about where you feel your strengths and your weaknesses are, and that may spread in that same viral way. But it's very hard, right? We all have a big, I think, I don't want to speak for everybody, but oftentimes in positions, our core identity is being a physician and being a good physician, that we take care of people, we don't make mistakes. And acknowledging that to a learner or to anyone, going back to our idea about power dynamics and issues with conflict, is very challenging. And I think it can be even more challenging depending on which the article we talked about, differences across gender and race and the full diversity spectrum. Those inherent societal power dynamics that can make those conversations harder as well.
And I thought that was really important because they don't really get into that in this, whether or not other things that would be the normal sort of inherent biases. How does that play into the acceptance of feedback as well? They don't really touch on.
Yeah, and I agree with you, because the residents all come in and they'll come in with a preconceived notion. And very frequently, especially when you're dealing with an incoming class, they might like the attending who sits there and says, let's look at the EKG and tell me. But that same attending might be the person who sends someone who's misdiagnoses and doesn't have the great skills and is actually just spending a lot of time with very basic stuff. And they're like, well, so-and-so doesn't spend time teaching. But in fact, through subtle ways and through teaching them how to think and to follow their cases, there's a preconceived notion. And I see that the residents come in and the attendings who are going over and going on the chalkboard and writing out the 5 kinds of things that are basic are the ones who are perceived as their great attendings. But those are also the ones that I look at their cases in retrospect, or I get the sign-outs. So I think it's really hard, in fact, if you're walking in with someone who doesn't necessarily appreciate that you're there, and developing this interaction, I think, is really important, and I think that's really good.
I actually had a conversation last night with some of my colleagues because Michigan is a historically incestuous program with all the residents there too. And we were talking about one of our former colleagues who has since left us a long time ago. And he was talking about how this guy was his favorite attending when he was a resident because he let him do whatever he wanted, right? And then he became an attending. He was his least favorite because he takes out of it like, you know, what the hell's going on with any of these people, right? And that idea that you're looking for as a resident, and, you know, I'll use a joke my grandfather uses. I tell my kids, you don't know what's good. Like, I don't want to eat that. You don't know what's good, right? Like, sometimes residents don't know what's good. And that's not their fault. And maybe they do know what's good, and we're being overly paternalistic. But I think this idea of an alliance and a discussion about what are you looking for, how can I provide that, changes that script really quickly, right?
So I totally walked in, I apologize, but I have a big comment about feedback. My name's Jeanette, I'm from the Mass Medical Center, they stay in my area sensitive. I think there's a huge difference between and in my mind, it's the waffles and the pancakes. So if you have two chief residents, and both of them are putting in a central line, and maybe you could do a little bit better serial technique. It's not simple. You know, I'm talking about group averages. There's people that are going over on the bell curve. But this is my impression. If you tell both of the chief residents that your content is you need to be more sterile when you put your central line in so that patients don't get a central line infection, and I noticed you get X, Y, or Z when you put in this line. I think the tendency for women is to immediately go, oh my God, they know I can't do a central line. I wonder if they know I didn't make that intubation 6 weeks ago. I wonder if I have a problem with my program. Should I get a new CV? Should I start thinking about transferring? Where I think with guys, so that's the pancake, you put the syrup on and it goes, whereas I think for guys, their problem is they stay in their waffle. So you say, you know, when you talk to the chargers like that, I don't think it's going to really help you get what you really want to get done, which is X, Y, or Z. And, you know, 24 hours later, you see them talking to the tech like that, and you're like, oh, we just sort of talked about this. I didn't talk to the chargers like that anymore. So this waffle, and I think sometimes it's our own blind spot. So how do we teach people how to recognize it, and how do we teach it ourselves? And I have no doubt that women are probably evaluated differently than our male attendings, and they're anonymous, and they feel threatening, and they hurt because you don't know which resident said it, and it's a terrible situation. And sometimes we don't teach our residents how to give good feedback, which is not a character flaw. It's can you do a specific thing right now to cut your next shift? What I do with my residents begin the shift is you tell me one thing we're going to work on at the beginning of the shift, you tell me to do that.
So I actually am really intrigued by both the sense of your social media problem, the sense of anonymous, and you know, the freedom that people feel like they have when they're anonymous. And I've kind of struggled with this a little bit in terms of, you know, I even at Vanderbilt for a period of time, it's like, let's let the attendings give anonymous feedback back to the residents. Except I gave them all a number, so 1 through 30. So they had to write their number down, and that just meant that I could, if they put something really inappropriate there, it's like you cannot put this anonymously on somebody's evaluation form. That is a sit-down conversation. So that anytime something was inappropriate, I could pull them back in. And I really started to think that perhaps we should be able to do that with the residents as well, is that it's anonymous to the person, but it's not anonymous perhaps to me as the program director, because constructive criticism helps us all, including the attendings. If you really felt like the attending wasn't, you know, doing well in something, but we are not going to go to the petty. This is not, you know, this is an issue of professionalism, and I would include that in our social media. We have something to work on. That is professional growth. Let's talk about it, but that is pettiness. And I'm going to use this as a weapon. And again, I struggle with this now with patient safety reporting. I have people saying they did PSN. When that, you know, when your reporting system for errors and adverse events becomes a verb, there's a problem. So again, that sense of how do we make this more professional? Because I love the word here that was the therapeutic alliance. And to make that, to twist that into sort of the educational alliance is, this is what I owe to you, but it's not just a one-way street, because the things that you all see could, you know, you can owe something to me to make me better, but rumor mongering behind our back is going to get us nowhere. And to your point, that still wouldn't, you know, that wouldn't necessarily still help us with some of the just inherent biases that come out when people engage with each other. But I was just really struck by it. You know, I'd love to be able to transform what they're saying here. Not quite sure how to do it in this fast-paced world of, and then again, to the points that we've made in the ED, you get to see these people for brief periods of time.
Well, we did a social media craft. All of our residencies where I'm from, that was social media, what can get you fired, what can make you lose your license.
I think that's really important now, incredibly important, because people just have gotten a little numb to what's appropriate versus not appropriate in there. I mean, that's just very troublesome.
And that's numerical.
I'm going to just follow up on some of the gender bias and how that may alter our interaction really fast. Just to throw it out, there are a couple of really interesting articles. One that was a qualitative analysis of evaluation comments in rooms of medicine that probably everyone has seen, that's come out within the past 6 months, and how recipients' gender will alter the comments provided. There's an interesting article called "Which You Would Be" that is more of a qualitative analysis of the experience of running codes and how gender code leadership and how gender interfaces with that. And there's another similar article that was in March's JG&E that I don't have the title
Judith
of.
London just put out an article in Emergency Medicine on that.
Okay. But I think people are starting to at least trying to characterize how some of the factors that can create differential power dynamics or alter the relationship among learner and educator, so on and so forth, may play out. Doesn't necessarily mean we have solutions, but understanding the environment is probably the first step to trying to develop solutions.
Can I just say one last thing? I think it's all the time with women is when you have to be very clear with women, especially our residents, when you're giving them feedback, that it's coming from a place that is not threatening. Because if not, it immediately comes from the content to the character, and it's totally twisted. And we feel super threatened, possibly in a different degree than many men do, because it is our character. And what we see all the time is I will see somebody get so defensive the first time somebody gives them critical feedback that, but yet, they get so defensive that that person's going, there's no way in hell I'm ever having this conversation again with this resident. And then they don't get feedback. And then when the program director sits down and says, you know, we've been hearing from the faculty, you have this huge, big thing you need to work on, they're blindsided. Well, nobody's ever told me that. So I think it's this trying to get residents to understand what is their role in receiving feedback. And how is this a skill that they're going to have to do the rest of their life to other people, whether they stay in academics or not, and teach that skill, because we are terrible at it, and our residents are terrible at it. So then it becomes this pithy comment that's not productive for anybody, it just kills morale.
I think that's a fascinating comment. We're starting to run out of time, so I think a lot of what I'm hearing is really interesting just in the way that it all relates. We talk about kind of gender stereotypes of social media, and we talk about kind of the learning environment, and really how that comes back into how your role is as kind of the physician creating this educational alliance, and it all kind of relates back to kind of I'm here in this moment, we're creating this bond, and a lot of it is affected by that learning environment and that relationship and that kind of support system that you're providing. And I think even with going back to the first article, I'm thinking about the power dynamics and the tensions that exist there. A lot of it, again, is interrelated. So what I'm hoping that you guys got out of this discussion that we've had is just kind of the moment you step back into the emergency department, the moment that you guys are interacting again with your residents, with your learners, you're at least considering all of these different things. It's a huge burden to kind of think about it being on top of you, and just you can it could weigh you down, but at least having some of this is that power to then say, I'm aware of this, I can start to work on it. So thank you guys for talking, we really appreciate it.
Thank you very much.